Hi, it's Henry Shelford here. I'm thrilled again to have Professor Graham Hughes for our latest in a line of Q&As with him on behalf of the Graham Hughes International Charity. Well, without further ado, hello, Graham.
Hello, thanks for inviting me.
Well, it is you are the founder of the charity, and I think everyone's always incredibly thrilled to hear from you. And it's great to have you up. So last time we were at your home,
Yes, down in the country.
which was a thrill, and I know Leo, who is part of the team, absolutely loved being down there.
Yeah.
And he came back saying, I'm sorry for being so late, but I was offered lunch, and I couldn't say no. It's so lovely. So he had a wonderful time, and I think everyone learned a lot on that Q&A. And as with all of them, we've been asking people to send in questions. So those watching, if you have any questions, so we've had some sent in, we'll work through those. And if you've got any additional questions, just post them in the comments. We're live on Facebook and on Twitter. We're looking at them both, and we'll pull the comments in the questions in as we go. Yeah, any problems with the feed or anything, do let us know as well. But I think we've got some people checking, and hopefully it's all going okay. So the first question we had, I know the answer's a bit sad. So because so many people, we always get so many comments from people who've been touched by you, by what you've done, often and sometimes have been treated by you. And our first question, which was sent in by Jill, was, does Professor Hughes see patients privately? And if so, how could I go about booking an appointment? I know the answer.
I'm sorry. Earlier this year, when the virus struck, we were all changed our situations, and I had to decide whether or not to go one extra year in the clinic. And the rules are pretty tight. You can't if you're not fully insured, etc. But what I do have is the team behind me at London Bridge Hospital, and they know which sort of patients I used to see, and they will make the appointment for one of the team. And what I try and do is discuss with the doctor seeing the patient and or seeing them, from a secondary point of view. I'm sorry to give such a negative answer to start with.
Yeah, and on the insurance point, the insurance is about you because of COVID
and doing the wrong thing.
And your slightly esteemed age. There's a personal issue that it's very difficult for you to be in hospital right now and treating people. And I think what you've said though is like, so GHIC actually has a number of, we have a large number of consultants listed on the website.
Yes.
We have who are leaders in their field. There are a number of whom are trustees of the charity,
yes.
And they are exceptional people who you've essentially handpicked to pass the baton on to.
I mean, at London Bridge Hospital, where I've been working for the last 15 years, we have the London Lupus Centre, and 8 of my team still work there full time. So I call them my mafia because I'm very pleased and proud of them.
And all of whom obviously work in the NHS, and so are
as well.
All of the experts involved in the UK work both in the NHS.
Yes, most of them are lupus clinics.
And you can always ask your GP for a specific referral. So if you go onto the GHIC website, you find a specialist you like, you can request that. So I think we do recommend that. So I knew that was a sad, but I know lots of people still want to meet with you for obvious reasons, and but that has changed, and that's a part of why you're putting a lot of your energy into the charity to sort of further communicate around Graham Hughes syndrome, around APS, and teach people and help people.
That's right. I think the main reason for my starting and getting involved with this charity is education, really. To anybody who is involved, either as a patient or as a family member, can learn more.
And that's Carolyn has sent in a question which perfectly, thank you, Carolyn, good job, perfectly segues into that, about talking about education. And she asks, how can we increase awareness amongst primary care and secondary care specialists and ensure that APS is included as a part of the curriculum in Doctors Foundation and core medical training.
Absolutely, Karen. This is our biggest concern over the years. I think probably it's true of every specialist in his own subject or her own subject, that it takes a long time to learn about what essentially seems like a new disease. It happened with lupus 30 years ago. Doctors didn't have much information on it. So the answer to your question, we're giving GP lectures. We have once a year a patients meeting, which will certainly be this year disrupted, of course. We'll certainly keep you posted about that. But we publish books, I've sort of several on Hughes syndrome, little booklets. And of course, doing what we're doing here with the TV.
And that's great. And I think one of the core of that question, right, is that you discovered the syndrome and have essentially been teaching everyone about it ever since.
That's true.
Because prior to that, they obviously didn't know. So it has been a lifelong passion and work to build up that presence and increase awareness. And part of GHIC's role is to particularly focus on increasing awareness around if you're having multiple. So actually, I think it'd be useful to recap on
symptoms,
on some of the symptoms and also the sort of warning signs or the potential bells that would suggest someone should go and ask about Graham-Hughes syndrome.
Yes. Well, the background is in one way very simple. We call it sticky blood. It's not quite scientifically exact, but it's where the blood has a tendency to clot abnormally, and so it can affect, for instance, veins in the legs, DVT, but it can sadly also affect major arteries such as heart attack, stroke, and so on. In other words, it can affect any organ of the body. So the poor patient getting this syndrome ends up by seeing cardiologists, nephrologists, rheumatologists, memory loss, the whole thing. The two organs that seem to be most sensitive are the brain, which I'll come back to, and in pregnancy, the placenta. So early clotting of placenta, these women get recurrent miscarriages, and that's a big aspect of the syndrome.
Yeah. And one of the things we're, as a charity, working on is to have it so that if someone has recurrent miscarriage, it's that they do automatically go and get a test for Graham-Hughes syndrome.
Yes.
And I think we're fighting to lower where the clinicians know to do that, but also to lower the number of
It's the same old thing. It's an antibody test, fairly simple, done in most teaching hospital level laboratories. So and we now know, for instance, miscarriage is the commonest treatable cause of recurrent miscarriage. So any woman, for instance, who's had 3 or 4 or 5 miscarriages, tragedy, should have been tested or should be tested.
Yeah, no, it's just an awful situation that has a potential resolution, because you've treated many people, and that's the result of them being able to carry it to term. And it's a big, very, very important thing, and a big part of what GHIC are doing, and why you founded the charity. So those are our first general questions. So we're going to move on to some about symptoms and side effects.
Sure.
And actually, you just talked about some about the brain. So Paula has written in. She said, I was diagnosed with APS 5 years ago. I have scar tissue due to another DVT and a bleed tumour on my brain. I'm experiencing worsening symptoms and increasing pain, but these concerns haven't been taken up by my haematologist. Am I right to be concerned? Is it normal for symptoms to become more prominent over time?
It can happen, definitely. Normal is a strong word, perhaps, but it's certainly a feature of the syndrome. It can come on, the commonest age perhaps is between 20 and 40, but it can, for instance, a lady who has miscarriages at 20 can, at the age of 40, start getting severe headaches, for example. Obviously, with your symptoms that you've just told me, you've got to be sure whether it's another diagnosis like an aneurysm or something like that. But in general, you certainly should be tested. I've devised a list of, I think, 40 symptoms that could be now that can do more harm than good, but that list will we'll put it together for our people who are involved with the charity, so that if you get several of these features, you should be strongly suspecting the diagnosis. The brain is a stupid organ because if it doesn't get enough oxygen, you get either headaches, and migraine is one of the commonest features, memory loss. I'll come back to that if I can, because that is a major feature of the syndrome, or even funny turns like seizures. For instance, teenagers with epilepsy, one of the known causes now is Hughes syndrome. So, and finally, we have a thing we call the 1 in 5 rule. I mean, a lot of conditions, such as DVT, 1 in 5 of those patients have sticky blood, which can be treated and diagnosed. 1 in 5 early strokes in under 40. 1 in 5 coronaries in women. This is a commoner disease in women than men, but it's still an important thing not to forget.
Talking of heart attacks in women,
yeah.
In the most recent speech, actually given by the Health Secretary Matt Hancock, he talked about one of the problems around the teaching of heart attacks was that they were still taught from the perspective of what it feels like for a man to have a heart attack.
Absolutely.
So I think it might be useful. Do you want to tell people what a heart attack feels like for a woman? What are the symptoms?
Yes. Well, the symptoms are obviously angina, which is chest pain on exertion or in the cold. And this can lead to an attack, which is more serious, of course, which is chest pain across the center, crushing pain, pain down the arms, and of course collapse and all the various more severe things. Now, yes, heart attacks traditionally much more common in men than women, which is why the people who published this paper, who came from Rome, they found that I think 40-year-olds, or maybe 45 women who had heart attacks, this was a major treatable cause. And I make a strong plea, and we're making it to the cardiology world, which is taking note, incidentally. We're seeing a lot more patients who have angina as their symptom. And if you're a woman aged 30 and getting angina, you really should think of this diagnosis because it's so treatable.
That's it's clearly very, very important.
Yeah.
I think that's a lot of what your fight is about. Is that Graham-Hughes syndrome can cause a lot of different things. And,
absolutely.
The treatment of it can then help those things. We've had a question in from Jan on Facebook. Can I ask if hyperthyroidism is linked to APS at all?
Thyroid problems are linked. APS is what we call an autoimmune disease, where your immune system attacks wrongly some of the organs, and in our disease it attacks the membranes of blood vessels as well as the platelets, the clotting platelets. And because it's an autoimmune disease, in the families of patients with Hughes syndrome, we see an increased number of thyroid problems, autoimmune thyroid, Hashimoto's, and a rise in numbers of other autoimmune diseases, such as lupus, multiple sclerosis. Not major, but definitely an increased incidence. So it's clearly a genetically determined disease in the background.
The link to autoimmune diseases. So.
Yes, autoimmune diseases are diseases where, on the whole, the body produces antibodies, which normally they should do for various things like flu virus and so on. But the antibodies, when the disease happens, are wrong, if you like, and they start attacking organs. So thyroid autoimmune disease is affected by thyroid antibodies. And if you look at a large family with Hughes syndrome, you'll find a number of patients with thyroid autoimmune disease. And that can go either way, as in your case, overactive thyroid, or more cases we see underactive.
Charlotte on Facebook wrote in, and she said, I'm currently on warfarin, suffering strong side effects and symptoms, and I'm getting bad infections, joint pain, migraines, and visual disturbances and bowel problems. I'm also on duloxetine to help with the pain. I'm struggling to maintain a quality of life. What would your advice be to help manage this?
It sounds like full-blown Hughes syndrome that you have. Now, many problems, but the one I'll take is the one where you're having problems with warfarin. Now, warfarin is a marvelous drug for patients who are getting early strokes and so on, because you're clear then you're theoretically not going to get a stroke because the thickened or sticky blood is effectively neutralized. However, warfarin is a pain in the butt because patients often get side effects. It interacts with drugs, and in your case, one has to ask for the list of painkillers and so on that you're having to take, which can interfere with the warfarin dosage. Food can affect it. And two answers to your question. One is, of course, I would hope you're under a physician who understands the concept of the Hughes syndrome. In your case, very important. The second answer as far as warfarin is concerned is many of my patients who are on warfarin self-test. Now, this is, you can buy a machine that finger prick test, and it tests your INR. Some doctors don't like this because they think that perhaps it's too much responsibility to give to an individual patient, but in patients who are having difficult times with warfarin, I find it very, very useful. And to do this in collaboration with your own anticoagulant clinic. Many of my patients who seem to be having problems with warfarin, if you look at their little cards that come for the INR, it seems to fluctuate up and down like a yo-yo. And many of the cases I see is that the warfarin dose is actually too low and not too high. And your INR, instead of being 3, is nearer 2. Now, I'm getting a bit technical there, I realize, but in other words, you're not fully treating the patient here. The patient needs to be monitored, may well need to be on a slightly higher dose of warfarin. I hope that's not too complex an answer.
I think it's fantastic. I think it's a very thorough answer. I'm going to risk something terrible, and I'm going to jump across my question list of the ones sent in and go out of order. So I will come back, but from this point it could all go wrong, people. But it's because it's related to what you were talking about.
Right.
So Andrea wrote in and said, "I'm on warfarin and I currently self-test using the portable handheld machine." So exactly what we were talking about, to measure the INR in my blood. Recently, I've been hearing some conflicting advice about using the machine versus getting a normal blood test. Is one better than the other?
No, one should be in collaboration with the other. Certainly some patients have a terrible time, even with their anticoagulant clinic. They don't get the results until the next day, etc. And that is improving. People are recognizing, anticoagulants are recognizing Hughes syndrome sometimes is more tricky to treat. So the answer to that one is, get to see your physician.
And why might people think that getting a sort of blood test in hospital is better than using a handheld device?
Partly tradition. I mean, we're all brought up on going to the anticoagulant clinic, and many patients now have a marvelous time. They can just pop in and they're telephoned when the results are abnormal and so on. That wasn't always the case.
Yeah. Yours and my definition of a marvellous time are definitely different.
Yes, anything near
going to the hospital.
Yes,
not it.
No, definitely not.
No, but I know what you mean. It's much better than it used to be.
It's much better. And although some clinics frown on the patient self-testing, I think if it's done intelligently in collaboration, the last little thing I'd say is occasionally the machines don't seem to work properly. I don't know why. Nobody knows really why. And there are some patients who absolutely specifically find that they can't get a correlation between the hospital results and their own. Lots of reasons, and I won't go into them now, but it is sometimes a headache.
Okay. And I imagine a hospital blood test obviously there's much more to it, or they may test other things as well, but the value of the test at home is that you can do it so much more frequently, and in doing so really get a measure of what level of treatment you need to do,
yes,
which isn't possible with a hospital visit.
I mean, you're right. For those who don't know about warfarin, you have to thin the blood. It's like the petrol's too rich in the car, and you have to thin it for the engine not to stutter. And in this situation, I was just trying to think of the number of cases I've seen like this. You really need to get the INR. Now, the INR is the international ratio, so it's like comparing full creamed milk with half cream milk, I would say. And the INR should be around 2 in most individuals, but in our disease, it's often over 3 when the headaches disappear. And for instance, in your case, headaches are a very good sign of the disease and whether you're winning or not in your treatment.
Fantastic. And right, I'm going to now try and go back to where I was in the questions. But one thing we are doing is pulling in questions, obviously, from the people who are posting. Wendy has posted a question, and she's saying, "Good morning from South Africa."
Ah, right.
So a global audience, which is a wonderful thing. Hello in South Africa. She says, thank you for doing these Q&A sessions. They are hugely appreciated.
That's nice, thank you.
My mum, who has Hughes syndrome, always seemed to have a cerebrospinal fluid leak. Can this affect the APS in any way? She's also getting severe leg muscle cramps, and the only thing that seems to help is salt.
Well, that makes sense. There are some people where, for instance, in your mother, it doesn't sound as if the antiphospholipid syndrome is the major cause. That it's an electrolyte imbalance, and salt and cramps, or the lack of one, goes with the other.
Okay.
So I don't think it's the same.
So the muscle cramps, don't think related to APS. But what about the cerebrospinal fluid leak?
No, I've not come across this, I must say. The neurosurgeons may have had some cases, but I haven't come across it. It's a hard one to imagine is linked because it's not a clotting disorder unless there's been a previous thrombosis in the spine. I'm sorry not to have an easy answer to that one, actually.
No, and also obviously one of the challenges of a disease as it's emerging is that level of surety can't be there, but you think very unlikely. Suzanne has sent in a question. She was first diagnosed with APS in 2006, has been taking anticoagulation medication ever since. Then 3 months ago, I was diagnosed with a non-alcoholic fatty liver. Is there any evidence that Hughes syndrome could have caused this, or could it be caused by any specific medication? So I think she's also asking, could it be Hughes syndrome? Could it be the medication? Or
Hughes syndrome certainly has been associated with this in some patients. Of course, it can be associated with medication, and you'd have to get a clear history together with your doctor for that. Yes, the liver is affected sometimes by a poor circulation, by sticky blood. Sometimes it's a clot, and the liver the patient gets a clot in the liver, which sometimes needs even surgery. In other patients, the clot is bypassed, as it happens in the legs, and you get big veins sticking out all over your tummy, which is bypassing the liver. So yes, if it's now becoming known that this can happen in the liver, and the way that the liver starts becoming sick is for fatty change seen in the liver. So yes, but again, don't forget the drugs, the medications.
But the medications, in your experience, will help the Hughes syndrome, which can help reduce the potential for this kind of consequence. But the medication itself.
Medication itself, yes. I was also thinking the opposite, where there's a list as long as your arm of drugs that can cause liver function abnormalities. Aspirin, it's common as that sometimes.
Right, and so Mandy sent in a question. I'm diagnosed with APS a year ago after a small DVT in my calf, and I'm currently on 20 milligrams of rivaroxaban. Numerous APS sites suggest that I should be on warfarin. What's your opinion?
Excuse me.
Right.
Warfarin traditionally has been the main drug for this because it's tried and tested. And although the media hate warfarin, they call it rat poison and things, but don't forget warfarin is
that's because it actually is in rat poison, right?
Well,
but in much higher quantities.
Well, that's the reason it works in poor old rats, because you give a massive dose and they eat it and they bleed. So sorry, I've forgotten what the question was talking about rats.
But most things in huge quantities are very, very bad for you,
Absolutely. Absolutely.
and dangerous. So it's not, caffeine, for example,
Yeah.
or
Yeah.
alcohol, etc. Um,
I
what was her
didn't.
question?
I
Sorry,
didn't
so it was
answer the
about
question. Yes,
rivaroxaban.
rivaroxaban.
So she's asking, is a APS site suggest
It-
what warfarin? Why would someone be put on that rather than warfarin? What's the sort of
The answer
pluses and
is
minuses?
quite simple. Over the years, we've become frustrated by warfarin and the problems of patients who, can't take it properly. And there's been fierce competition in the medical pharmaceutical world for new non-warfarin oral anticoagulants. There's half a dozen around. We were very excited, and so about the possibility of changing to these several years ago. There's very little in the way of published data. There's a recent big trial from London showing that it probably is not as great a success as warfarin, but time will tell on that. So it's something we're all hoping for desperately. And if in your case you're doing well and there's lack of symptoms or headaches, stick with it. But the data has shown that in severe cases, with, for instance, recurrent mini strokes, there have been more relapses on these new drugs than on warfarin. So the jury is out on this at the moment.
And I imagine one of the sentiments to asking for Lynn to ask that question, sorry, Mandy to ask that question, is you don't want to find out your medication is not working by having a stroke.
No.
So how can she be confident? Like, what does good feel like, and how can she feel confident that she's probably
I think
on the right
the
side?
patient's history is very helpful here, very helpful. And if that patient, for instance, gets migraine, which is the number 2 commonest feature of Hughes syndrome, and those attacks start getting more, then it makes sense. You've got to act as a doctor and treat slightly more aggressively, either up the warfarin or the other tablets. Warfarin is easier because you have a measurement with your INR. So her symptoms are worrying, and therefore she should be seeing her own doctor or physician in the hospital to monitor.
Okay. So she should look at her some more minor symptoms.
Absolutely.
Well, as far as migraine does not feel
It's
migraine
it's
at
not.
the time, hey? But look at those, say, more temporary symptoms, and if they're
Yes.
rising or significant.
Absolutely.
And
I said that migraine is the second commonest feature, and the first commonest feature of Hughes syndrome is memory loss. And again, the brain not liking the lack of oxygen, one of the things that is affected is memory, and patients think, oh my God, I'm the joke of the family, I can't remember names. And if that suddenly changes or in worsening, it's almost certainly due to ischemia from the sticky blood.
Yeah, great. I think that's very insightful and interesting and important for people to know those alarm signals. Lynn has asked, I'm aware that some medications can cause APS. Do you have any insight into what percentage of APS is caused by Dilantin specifically?
Yeah.
And how can one pinpoint Dilantin as the cause of APS?
Luckily, it does seem to be a low percentage, Lynn. There are certain, you mentioned one, but there are a few reports of certain medications causing an increase in blood stickiness. I get to see a lot of the reports with my little role as the editor of the Lupus Journal, and I think the answer is it's rare. You stop the drug if it's felt that this is the case. Dilantin, luckily, is not so widely used anymore. But in another disease related to Hughes syndrome called lupus, there are a small number of drugs that can cause a lupus-like rash and symptoms as well. Stopping the drug stops the disease.
We've had a number of questions around, as we do every time, around sort of very specific things, which I think is quite useful for people as they look at their own diagnostics. So Lauren has written in She said, do the following combined results signal a need for an anticoagulant? Positive LAC, high levels of factor XA, high levels of antithrombin 3, and high levels of protein C activity due to increased consumption.
Yes, they do. They're very helpful to us. And having a full house, as it were, of those makes one suspect that this is the correct diagnosis. For the antiphospholipid antibodies, which is the APL, the true antibody, there are currently 3 blood tests that the doctor does. You don't have to bother about them yourself because the lab nowadays should be testing a blood sample with all 3, and they are an ACL, anticardiolipin, lupus anticoagulant, which is a terrible name because it's not lupus, but historically it was called that. And the third one's anti-beta 2. Now those 3 sound a bit confusing, and I wouldn't be involved, but the scientists testing these show that if you, in those cases of antibodies, if you have all 3 positive, you're at higher chance of clotting than only 2 positive or 1.
Okay, and so in this case, and obviously just to be very clear, like this is not a medical consultation. This is like
right.
trying to provide information, and you must talk to your individual consultant. Right, disclaimer aside, but the more an increased number of those
of those 3 particularly, yes.
And if you have all 3 high, then that suggests high risk.
Yes, and high levels, I should say, high antibody titers.
Right.
Yeah.
Right. We've had a couple of questions sent in, and which we're going to get to, and then that'll be the end of the sort of medication and treatment section. And then we have a question about diagnosis and care. Ali sent in a question on Facebook. Have there been any recent changes or developments in the way MS-type symptoms are treated? For the last 14 years, I've been treated with anticoagulants for a wide range of symptoms, but now I'm being told I have obstetric APS and should no longer be treated with anticoagulants. What is the reason for this change?
I don't know the reason for that. I really don't. I mean, a person who has the features that you have, it's important to get their diagnosis correct. Perhaps I can go back to your question, but you say you have MS-type symptoms at the moment. I wasn't sure, to be honest.
She has said that. What's she saying when she says she's got MS-type symptoms? Is that?
Yes, I mean, one of the parts of the body that's affected by sticky blood is the spinal cord, same as the brain. And if it affects the spinal cord, you get loss of sensation in various parts of the body. You'll get, but you get a lot of MS-like features. Double vision, for instance, speech disturbance, balance problems, pins and needles in the arms and legs. They're all features that MS causes as well, and quite a lot of other things do too. So the great excitement was 20 years ago when we found that some of our so-called MS patients were not MS but were Hughes syndrome. Opened up a huge interest in research of this. The story has not been as black and white as one would hope, actually, but certainly there are a small number of patients, we have a number of them, whose first label was MS, but it turned out was actually Hughes syndrome. And one of the most remarkable patients, I'm not going to name names obviously, but she was in a wheelchair, shaking so badly that she was thrown out of the wheelchair on one occasion and was labeled as MS. And in fact, nature took a hand. She got a clot, I think, in the leg, and bit by bit the penny dropped. She had Hughes syndrome, and all her symptoms have gone on warfarin. She's on lifelong warfarin, goes to dances, does everything.
Well, and this Ali has said that she's got obstetric APS.
Yeah.
What does that mean?
I think it's dangerous. Yes, there are some doctors in my world of research into APS who have suggested calling it obstetric APS because it causes the miscarriages, etc., but the patient doesn't have any other problem. But sadly, we have seen patients like this, as I mentioned earlier, who go on to get other problems like DVT or whatever. So I think it's a dangerous label to think that it's a separate disease.
And so therefore, like what would your view be on no longer having anticoagulants?
I would be
potentially,
worried about stopping. I really would
So,
say this is not a medical consultation, but
no, yes, it's not a medical
no,
consultation. But I think your point of passion is that the Graham-Hughes syndrome is usually helped by anticoagulants.
oh yes,
And,
oh yes,
and that's an important thing to consider.
yeah.
Okay, great. Now we've had 2 questions sent in, and one from Anne, who I understand is very keen to ask this question. And she's, first of all, she says hello. She says you've met and she's been a patient of yours in the past. And as a reminder, this is not a medical consultation. We're not meeting with anyone. And we're trying to provide sort of wider advice, which then can be used for other people. So often your question, although it's you asking it, is there's many people who want to know the answer, and that's the point of these, to bring those out. We'll also be transcribing them onto the website to provide a sort of more detailed Q&A for people who want to learn about it that way. And there's a good point at which I can say that obviously the charity, all of this is only possible through your donations, and there is a donation button on the website, and anything you can give is incredibly important, and we receive no government funds, and that is absolutely essential. So and as you know, it's very hard for all charities, so do please consider donating, and thank you. And now Anne, who's been waiting patiently. I'm being treated with anti-epileptic meds for seizures. I've recently been having, I have lupus, APS, and Sjogren's. I am taking aspirin as a blood thinner. I'm worried that no one is looking at the blood clotting side of this. Should I be on should anti-epileptic medication be considered, or is the risk of blood clots too high? So I think there's an interesting question about anti-epileptic drugs and the interaction with anti-clotting.
Yes. Very important, because we now know that seizures are included as a major feature in some patients with Hughes syndrome. In fact, there's one study that showed that the same figure, 1 in 5 of teenage epileptics is associated with sticky blood, treatable. So it's a big story. Now, in Anne's case, clearly they're linked, and the fact that she's getting a lot more seizures possibly means you ought to be looking more strongly at the level of anticoagulation, or whether you're getting any at all significantly. So back to the clinic, I think, in your case. I'll tell you a very interesting story.
We are always interested.
Well, an American lady who came to live in London was referred to me because she had lupus, and my colleague in the States asked her to see me. And she had lupus, which was mild in her case, but her major problem was epilepsy, so severe that she was on, I think, 7 anti-epileptic drugs. And fate took a hand. Within a week of coming to London, she got a deep vein thrombosis in her leg. To cut a very long story short, she started on warfarin, is now on warfarin. Frequency of epilepsy plummeted, and she's now on 1 anti-epileptic drug alone. So here's a lady who, yes, she had lupus, but her main problem was seizures, and effectively stopped when the blood was made thinner.
Wow. And anti-epileptic drugs, can they cause coagulation, or are these 2 separate things?
On the whole, they're separate things.
The epilepsy could be caused by the Graham-Hughes syndrome.
Yes,
and that would
be the major link.
And I assume there is also a group of people who have epilepsy for another reason and Graham-Hughes syndrome.
Maybe, yes.
That could be it. So I think, I hope, Anne, that's helped. It does sound like she should talk to her consultant.
Yes, an upgrade.
And refer to this conversation. But as with everyone, talk to your consultant. Jenny has sent in a question. I have very high test results on all 3 antibodies, something we've covered already today. First tested positive 20 years ago. I've had a DVT, recently a stroke while trying to have a baby. My hematologist wants me to transition away from Cleaxane back to warfarin and baby aspirin. He wants me to eat broccoli every day because he said it helps to balance the INR. Is this a common procedure?
So I gather that she was on heparin, has now had the pregnancy, and they're talking after delivery of going back onto warfarin?
I think she's actually currently on Clexane,
Clexane, which is heparin, yeah.
Okay, and is considering going back to warfarin and baby aspirin.
Yeah. Okay, well, often following the pregnancy, in what we call the lupus pregnancy clinic, where we see patients with Hughes syndrome, once the pregnancy is successful and over, then you'd certainly come back off heparin, because heparin is a great drug, but it's an injection. You don't want to be, if you can, on injections daily for years and years. Maybe I'd like to come back to heparin on that one, actually, if I may. But in her case, she should be considered, depending how bad her history's been in terms of clotting, to go back onto something like warfarin if she's still getting problems. Did you say she'd had a recent stroke?
Yes, whilst trying to have a baby. Yes. Yeah.
See, that puts her in a very strong situation to be considered for anticoagulation. Who wants a stroke?
She's got a very good question coming up, but you want to talk about heparin, and I've now become very interested in broccoli.
Oh, broccoli! Yeah. Well, the trouble with that brings us back to warfarin, actually, because one of the problems with warfarin, it interacts with certain foods, and green vegetables especially alter the metabolism of warfarin in the body. So your average person who goes one dose Monday to Friday at the weekend, changes their diet a lot, the INR can be knocked out of control. But
in what direction?
Both directions, but it make the blood thinner. I think I'm just going back to that. But you can't. Some people do that. They take broccoli daily or other things daily. The main problem with warfarin is if you're an average bloke, for instance, goes out for a pint or two at the weekend, that alters it. So many things alter the INR. So most of my patients on warfarin tend to know what affects them, such as greens, and as long as you're eating the same amount of broccoli or whatever, then there's no problem. But if it changes that, then your dose of warfarin changes. Sounds very technical, doesn't it, really? But more nuisance value than anything else.
So, and why do you think it would be suggested to eat broccoli every day? Would that to perhaps stabilise
it? Yes, maybe keep you on a lower dose of warfarin, to stabilise it. But I would just take the right dose of warfarin myself.
Fair enough. Right, I'm going to straighten my tie slightly, make sure, because this question is clearly going to get clipped for the website and become an important part of it. This is Jenny's second part of her question. Jenny asks, what are the medical recommendations for someone like me who is prone to clotting and wanting to get pregnant?
You can go ahead and have another pregnancy. The main thing is in the assessment that you're then seeing someone, probably as you have been, who is an expert in Hughes syndrome and pregnancy. And more obstetric clinics now do have special interest in this side of obstetrics. You know the risks. She should be on something for the next pregnancy, and that something nowadays is usually a combination of aspirin and heparin. And the third thing, which is obvious, but it's so important, is to get yourself under an obstetric team who have links with people who, if not them, who are interested in the antiphospholipid syndrome. So I hope that answers your question.
I think it does. I think that's a very interesting, important point that you want to have when you want to have a specialist team or person there.
Yeah.
To talk to you about that, who has a particular interest. We're moving on to some other questions. So diagnostics and care. Then we've had a few other questions in. Susan asks, I think I may have Hughes syndrome. I've so far been diagnosed with SLE sarcoidosis. I momentarily stopped because, as you know, I'm involved with Sarcoidosis UK, and was myself diagnosed with sarcoidosis a while back. I've got anyway. Susan. I'm sorry. We'll focus on you. This is not about me. I think I may have Hughes syndrome. So far, I've been diagnosed with SLE, sarcoidosis, Sjögren's syndrome, whilst repeat blood tests show that anticardiolipin and lupus anticoagulant positivity, I've also had 2 miscarriages and suffer frequent ocular migraines through no history of DVT or pulmonary embolism. Does any of this look like it could be APS?
Yes, yes, yes. No doubt about it. If take lupus and Sjogren's syndrome, both very similar. Sjogren's is in a way like a milder, slightly older age lupus, but still has the same potential with antibodies and things to cause medical problems. But the same old figure in lupus is 1 in 5 lupus patients have Hughes syndrome features. I don't know why this figure keeps coming up, but you certainly sound as if you have the features of the antiphospholipid syndrome, and clearly you should be tested by people who are expert. I should say that there are 3 tests which we normally use, but for those who are negative to all 3, there are rare patients who have got the syndrome when the tests are negative. And I think in this case, you've got to use the doctor has to use their clinical judgment. We call this seronegative APS if the tests are negative. Very difficult, of course, because it's against the odds, but it does occur. Sometimes we ask the patient to take aspirin on a trial and error basis. In some, we'd use 2 weeks of heparin. I'll come back to that, as you mentioned, and treatment.
Okay, and now a good a question we've had in is, well, we need to point out, we need to say thank you to Suzanne, who said, thank you for asking Professor Hughes my question. I'm glad I'm getting credit. It's really you for answering it. And to thank him, I will be making a donation to the charity.
Thank you.
Thank you very much, Suzanne. We can do nothing without you, so thank you, and donations like that, so thank you. Charlotte asked a question, can stress make APS worse?
Yes, clinically it can do actually, but then that's a very general thing with most most diseases. Yes, we've seen the features coming out in someone going through unexpected stress. How to measure that, we don't really know, but the answer is yes.
And then Alexandra has asked a question. So she had a stem cell transplant last year for lupus, which has made it manageable. And a lot of actually, let's start on that. Stem cells.
Started, I don't know, 20 or 30 years ago, been found in some cases of lupus to help. It's obviously an expensive, extreme solution, and the data has not been totally great in lupus. Some patients have done very well and some not. But to put it in context, I think we've had 4,000 lupus patients on our books when I was at St. Thomas's, and I think we only had 1 patient who'd had this treatment. So I'm interested in your question.
Which has made it manageable, and lots of symptoms have improved, but the APS has got a lot worse with 2 new DVTs on anticoagulants. If APS is autoimmune, why did I not get an improvement from the transplant like I did with lupus?
Well, you've floored me. Very important observations, but stem cell, it may be that stem cell is not the treatment for Hughes syndrome, judging by your single case. It's difficult. Stem cell has been more effective in certain diseases than others. That's all I can really say on that. But the fact now that you're getting so severe a case of Hughes syndrome means that you need to be reassessed. But hopefully you are seeing somebody or a specialist in the lupus or Hughes syndrome.
Alexandra, you've successfully floored him. It's so difficult. Still, I think, had some information.
Well, if you look at lupus patients, say the 1 in 5 who have the Hughes syndrome, the Hughes syndrome can be the more severe side of the illness. And like my lady from America, who's, was seizures, were her major problem. So, and in lupus patients, some syndromes called like miscarriage, or like, just trying to think of another one, they can be more due to APS in lupus than any lupus itself aspects. We once did a study in our lupus clinic at St. Thomas's and found that lupus patients who didn't have the antibody had normal pregnancy histories.
So we've had, thank you for that. We've had a question from Bernadette. Last week my INR was 2.8. and I do home testing. Prior to testing, I had severe migraine and speech problems. My range was changed to 3 this year due to bleeding in my stomach. I find it hard to keep a balance and having more migraines and memory problems due to the tight range. I find I become symptomatic at 2.9. My range used to be 3.5 to 4, and my symptoms stayed stable. But after having the bleed in my stomach, um, how long will I have to stay in the lower range? I think and I think it'd be interesting just to hear your views on the range that people need to sit in.
Yes. I mean, it's such an important question, this one. It's something that we see once a week in our clinic. Major problem with someone who's had a bleed, what do you do? And it's different in every case. In your case, where there's a bleed on the stomach, the first question is, were you on any other tablets, such as aspirin, that can do that? Or did it come straight out of the blue? What you say about the level of your INR is so, so important. And it's very worrying that you're getting headaches and so on this dose of INR. In many cases, we will add in an anti-ulcer medication. I mean, it's adding another tablet, but something to stop the acid forming in the stomach that causes ulcers. In others, we will try having a holiday from warfarin for a while and trying one of the new anticoagulants, but the same applies. They can cause thinning of the blood in a dangerously thin area, can cause bleeding. So I think it's a fine tightrope that we don't know what to do. We sometimes add in other medications. We've even used steroids in 1 or 2 patients, but it needs close collaboration between you and your clinician here.
And I think we're coming to the end of, you've been very generous with your time, and I think we've got you, but I'm sure we're going to do another one. So any questions we've not got to,
Sure.
We've still got a couple, but we're definitely coming to the end. But any questions we've not got to, we will keep back and we'll look to ask them next time. We are currently scheduling for the chairman of the charity, Arvind, who is also a consultant specialist, to talk. He will also specifically will talk more about COVID and updates on that. So Jan, we'll come to your question there on that one. Otherwise, obviously, the default answer is you need to always talk to your consultant. But he's going to talk more around that. Thank you, Connor, for saying thank you. These things are very much appreciated. We've got one more question that we need to deal with. I think I know who wrote it, but it doesn't have. Oh, sorry, Suzanne Jones. She writes, someone has a very special birthday coming up next month. I believe you're going to be going to be 80.
I'm not sure what age I am.
My question is, how are you going to reduce the huge number of friends, colleagues, former patients who have become friends, and your family to help you celebrate when you're only allowed 6?
I'm going to hide.
Yeah, where's it?
I'm not going to have.
You're going to hide away.
Yes.
Be very sensible.
Thanks, Suzanne.
It has been wonderful as ever. Like, it's just I learned so much through these. I know they're hugely valued. I know we've got a lot of people watching. If you've got any more questions, do add them, and we will store them up for next time. And obviously, this is the bit where I have to pitch for the charity again, saying that we can do nothing without your donations. It is incredibly important. You can hear some of what we're trying to do, in particular, trying to look towards increasing awareness of the condition, helping people, looking to fund research, providing quality information and support, as you're seeing in this today. And so if you feel you can support us and donate, that's hugely appreciated. And then obviously my most important thing is to say thank you to you. There's always thank you for all you've done, but thank you particularly for this last hour and for your help for answering all these questions. Thank you so much, and thank you very much.
My pleasure.
I think that just leaves it for me to sign off. So thank you everyone for joining. Thank you for your time. We will be doing more of these. We'll schedule another one with Graham and announce that. So there's going to be one with Arvind, which I think people will really enjoy. And we're going to bring in more specialists and people providing this. If there's information you want on the website, please let us know. But obviously, and otherwise, please donate. And thank you very much for joining us. Thank you, everyone. Thank you again to Graham. Thank you very much. And goodbye.